Cardiovascular Webinar. My name is Fathi Idris. I'm a cardiologist in the United States. It's my privilege and honor to present, to be the chair of this session and to introduce two of my best friends and colleagues, Dr.Mehiar El-hamdani, who's an interventional cardiologist in the United States, and Dr.Adel Dyub, who's a cardiac surgeon in Canada. Adel and Mehiar will present two interesting presentations discussing cardiac surgery as well as peripheral arterial disease. We'll start by Dr. Dyub's presentation. Throughout the presentation, there will be a couple of questions that you can participate by voting in the answers. Without further ado, I would like to introduce Dr. Adel Dyub. Go ahead, Adel. The floor is yours.
Good afternoon, everyone. Thanks, first for the kind invitation, and thanks for the opportunity to present this interesting case in this webinar. It's been a while since the last time I presented. The title of the presentation today is an obstructive thrombosed mechanical valve. So I'm just going to present this first, and this is a 79 years old lady who was referred to me sometime in October with a history over the phone by a cardiologist that she had a sudden onset of shortness of breath this morning, and we're talking about 4 p.m. in the afternoon, and she had a prior history of sudden onset of abdominal pain. She's been in hospital 4 days ago. She was sent home after a negative workup, including a CT abdomen. Another further information we got was she had a colonoscopy done for some lower GI issues, and she had been on Coumadin, which was put on hold, and she was asked to resume her Coumadin 2 days ago. It was bridged with fragment. She lives alone, and she's a very deconditioned lady, and she uses a walker. And when we look at the past medical history that we obtained from the record, she had a mechanical valve done in 1997. She had a severe COPD. When she came in the blood work, she had evidence of mild renal insufficiency with creatinine around 161. She does have peripheral vascular disease. When we looked at the CT abdomen that was done in 94, also to night before, when she came in with abdominal pain. As I indicated earlier, she had a poor mobility issue indicated by the family. She had multiple falls in the last few years. Last echo on her follow-up by her cardiologist in the community hospital showed a well-functioning prostatic valve, mechanical valve with a mean gradient of 10, and that was done in June 2015. Medications: warfarin, Ventolin, Advair, Crestor, Atacand, and vitamins, just the usual. When she came to the ER, she had a blood pressure around 100/48. She was in regular rhythm, a heart rate of 120 beats. She's standing 96 on 5 liters. She actually required more help. She was requiring diuresis, and she was actually put on BiPAP, and a stat echo was done and showed that there's a mean gradient of 40 and a valve area of 0.3. And she had a chest X-ray showed that she was on pleural edema, and her INR at presentation was 1.3, and hemoglobin was 84, and she had also troponin pulse. So the community cardiologist talked to our CCU team, and they accepted her right away and transferred her very quickly. For phone message I got is, you need to open the OR, and this is a patient with a thrombosed valve that needs to go to the OR ASAP. So unfortunately, I don't have the X-ray, but it doesn't show much except the usual congestion, pulmonary edema type of. So this patient now arrived in our institution. By the time I drove to the hospital, she was next to the bed in the CAT. It's literally an angiogram. But I would ask the audience, or with us today, what would be the next step in a patient like this if you presented this way and came to you and you've got all this information? Which imaging, or what's the next step that you would like to ask to confirm your diagnosis? I'll give you some time to think and get the answer back. Okay. Nobody wants to do even a transthoracic. Okay. Basically, she was on the cath lab, and I said, well, go ahead because I need to do the fluoroscopy. I agree, fluoroscopy and echo are the two most commonly used diagnostic tools for diagnosing this kind of problem. But since we are on the cath, ahead and do the full cath, look at the coronary, give us a few images. So here's the image. You can see the cath. There's like at least 4 or 5 different angle different views. You can see the limited mobility of the disc here. One of the discs looks like it, and then the other one is looks like a limited mobility. This is a root chart that shows that there is a significant degree of AI that goes along with the diagnosis. That goes. There's another view that shows a very limited mobility of the mechanical valve. And you can see some mobility, which in a way it's a bit of assuring, not like it's very properly planned, but it does move a little bit, but it's only one side. And the view here, the view here. So basically, with this, I think we made a diagnosis of a thrombosed mechanical valve. And the patient right now she was actually intubated because she couldn't lie flat when they had her on the cath table. She deteriorated and there was a hesitancy by the team to do it. So we have to call the anesthesia staff on call to intubate her. She tolerated that, but she started requiring inotropes. She is now on a moderate dose of levophed to keep her pressure around 100, no tachycardia, statin fine, but she's now intubated on the table. Unfortunately, when they tried, I was in the cath lab and multiple attempts at femoral failed. There's no pulse in the femoral. Went ahead with a radial approach, and I was asked to take this patient to the OR. So I was asked what will be the next step. I would stop the video at this point and go back to the patient. Now you made a diagnosis. You're 100% sure with the story that you get from the referring physician with your fluoroscopy images that you're dealing with somebody with those mechanical valve, cardiogenic shock, and last 4 symptoms in heart failure. So what would be the treatment options? Again, I would wait for the response, whether you go for an emergency surgery, you just anticoagulate, you conservatively treat, or you give TPA or thrombolysis. Type of valve I was told was St. Jude by leaflet, according to the note. Although I was looking for more detail, but I didn't have the opposite note, but I was told that it was St. Jude. I think St. Jude most is by leaflet. I'm not mistaken. Let's see whether it's a tilting disc or not. We did have a coronaries, and coronaries were normal along this shot that I showed, which I didn't want to bother showing the coronaries because the coronaries were normal. Okay, so thrombolysis is 42%, emergency surgery 14%. You calculate only. Okay. So what I did actually, I think I'm going to discuss the management here before I go to the guidelines. I did manage to initially there was a lot of pressure on operating this lady, and I asked about family, if there's any family member, because we'd like to discuss with them. She's now intubated. We need to do something about her. But I need to discuss the management plan. So we've had, in my mind, at that time, 2 options. One is less invasive, which is thrombolytic. I didn't want to take her to the OR and take her chance. But knowing that she's a redo, knowing that she is almost 80, she had a bad COPD. She is very conditioned, in a very good shape to tolerate a big major operation like this. felt that we should have a serious conversation with family and explain everything to them. And first thing when I met the family, one of the daughters tells me that she was in the office with the cardiologist a few years ago, and that was a few years ago when she was this valve need to be changed because it's been 17, 18 years. He tells her, you never go for a redo surgery because your condition will not tolerate because of her bad lungs. She smoked for many years. She's FEV1 of 0.9 or something. She had bad lungs and puffers. She is really conditioned. And at any rate, so I asked her, there are two options: surgery, which is probably gives you, has about at least 25-20% risk of mortality, stroke and bleeding, and they're associated with surgery. And the other option would be thrombolytic. One thing when I was thinking about surgery is that the fact that the cardiologist was struggling with the pulses in the femoral, plus the look of the abdominal and the peripheral vascular disease she had, persuaded me to go away from surgery as much as I can, because when you do these kind of surgery, especially in the redo setting, you'd like to have at least femoral access. You need to establish bypass sometimes before go on, because it might not be a very good scene once the patient crashes. I don't know, it's at least exposed, even cannulate. So that was again one of the major determinants of the decision making is the lack the disease access issue. And people could make an argument about using accelerated cannulation and things like that, but again, you need still, it takes time to do it. If the patient becomes unstable, it's not a good option. So at any rate, the family accepted to go for the thrombolytic. In the meantime, I did a quick search of the literature. I made a call to the thrombosis team and their advice, their experience with previous cases. And we all agreed at the end that we anticoagulate with IV heparin and watch her for a few hours and go from there. And if patient hemodynamics change, worsen, then we can give TPA. So what we did is we observed her. I think it was 9 p.m. by the time I left. And I called. We're still stable, okay, no issues. But by 2 a.m. she received the TPA dose. I think she gave 100 milligrams. The next morning she's off levophed. Her echo the afternoon, the next morning, showed a mean gradient of 15. Repeat echo, and 3 days later, well-functioning prosthetic valve with mean gradient of 10, and she went home day 6. So in summary, for this case, you have a 79 years old lady with known history of previous mechanical valve 20 years ago, with a background history of severe COPD. She is very deconditioned, came in with shortness of breath, reached sudden onset on the same day, and she was found to have an INR that is subtherapeutic at 1.3, and an echo diagnosis and fluoroscopy diagnosis of thrombosis mechanical valve. She's intubated, hemodynamically unstable, and she requires inotropic support, and now she's in CCU. And so we had a diagnosis of thrombosis mechanical valve. So the treatment option we talked about, and we decided to proceed with thrombolysis using the TPA. I would go next to the guidelines, what the guidelines tell us. If you look at the guidelines, the two major determinants of determining which approach, whether you do medical therapy or surgical, it seems to be to look at is the way they present, the acuity, and the size of thrombus. And it is a class 2A for the medical therapy to use thrombolytics if the patient comes within 14 days onset of symptoms with a class 1 to 2 symptoms and a small thrombus less than 0.8. Somebody has to tell me how you're going to determine this, whether by TE or CT or whatever method, but we talk about size of thrombus, we talk about the way the symptoms are presentation. And it seems to be more consistent when you look at the right side. If somebody had a thrombosed right side valve, there's more people in favor of using fibrinolytic therapy in thrombosed lifestyle. Again, level of evidence is B and is a class 2A. For surgery, emergency surgery is recommended for patients with thrombosed left-sided prosthetic valve when they presented to you with a class 3 or 4, like the way that we have Our Lady. Emergency surgery is class 2A if people have a thrombosed left-side valve or they also mobile or large thrombus more than 0.8 centimeters. But you have to remember, if you read most the observational studies that have been done on this, you look at most age group of people treated, and most of these guidelines extrapolate. You're talking about people mean age between 35 and 59. So I think it's very important to make that distinction clearly, because medicine, yes, there's evidence based and guidelines, but I think also sometimes there's ways of individualized medicine. I think outside the guidelines. But anyway, these are the guidelines in terms of when you do a meeting paper that was recently published by a group from Mayo Clinic in Boston, and it's an American paper. And what they decide here is to look at two modalities of treatment of people with thrombosed prosthetic valve and treated by either thrombolytic or surgery. So if you they've looked at about 662 patients when they looked at about 17 studies from 1996 to 2012, and they came up with two pools of patients: 752 patients treated with thrombolytics, and compared them to 662 patients treated with the surgery. And even in surgery, when they look at operative findings, they look at what are the findings causing obstruction of the valve. And if you look at the first slide here, there is majority, I would say 60% or so, have some sort of pannus formation. What is having a pannus already in place would make probably the thrombolytic treatment not as effective as we to do. If you look at the anticoagulation status at the time of presentation, only 60% had adequate presentation, has adequate anticoagulation, meaning 40% came with inadequate presentation or of anticoagulation. So you still, even though you are anticoagulated, have different those obstructive mechanical valve. The outcome for people who had thrombolysis, about 756 patients. If you look at the usually female are mostly more affected than male. The other thing is you have to make a distinction. There's more than 2/3 of patients are mitral valve. Our case today we're talking about aortic. So mitral position affected more than the aortic. We've had more people sicker, about 2/3, 1/3 in class 1 and 2 versus class 3 and 4. The recurrence rate after thrombolysis is about 13%. Stroke risk was 15%. That is the major thing against using TPA in those valves. If you talk to cardiologists, everybody is very worried about the risk of stroke in these people when you might see. Subgroup who had complete success, 8%, and those who failed thrombolytic and particularly undergo surgery, they still have a really reasonable mortality rate, 12%. If we go next to show the outcome based on patients who had complete success with thrombolysis, depending on how you present. If you present with mild symptoms, you have an 81% chance of success. If you present with severe symptoms, class 3-4, your success rate is around 74%. If you look at the outcome for the surgical arm, surgical treatment for people with prosthetic valve thrombosis, you're looking at, again, pretty much the same, more female. Here is the difference. Recurrence is less, 6%. CVA, stroke emboli, 6%, but mortality is slightly high, 15%. So it's a trade-off. You have less stroke, you have less recurrence, but your mortality rate is 15%, which I thought really low. If I talked to my lady when I looked at her, I think given her age and her pre-morbid condition, I was very generous by saying 25%. So conclusion, fluoroscopy and TE are the main imaging, according to this paper, to diagnose mechanical valve. 39% of patients had subtherapeutic anticoagulation at presentation. Mitral valve is the most commonly affected valve. Female most common, more than male affected with this condition. Seems to be the thrombolytic treatment choice as initial treatment for people with affected valve disease. When it comes to thrombolytics, have a risk of stroke of 15%, recurrence rate of 15%. Complete success is achieved in 70%, and mortality is about 8%. And in surgery, 81% will have a success in people with class 3 to 34. Mortality is around 15%, lower recurrence rate, and lower stroke rate. Thank you, and I'd like to play the last video that it does not belong to this case, but it's a different video we've changed and try to show you the benefit of this for the use of thrombolytics. Female patient, 61 years old, 2 years ago, she had a mechanical prosthesis. She had actually this lady was treated with thrombolysis, and you can see here is the partial, which is again give her 1 dose of thrombolytics, some improvement of one of the discs. Second dose, as more improvement of the movement of the discs. After the 4th dose, now we're talking about both leaflets moving nicely. And this is again another concept of how many doses of thrombolytics, because a lot of people they say give 1 and wait and see the effect on hemodynamics and blood pressure as required in the final field. And here we're seeing the extreme where 4 doses of thrombolytics were given, which resulted in resolution. But I think this is, you have to make sure that this is, if you look at the history, this used to be a very acute form, the one that has sinus formation, that is not going to work. But this is a classic demonstration of when there is a fresh clot, you could lyse it and you could actually recover function of the valve. Thank you.
Thank you so much, Adel. Great presentation and really challenging case. It's always good to see a surgeon that his answer is medical therapy. So that's something good. Did you? So the floor is open for questions. Anybody has any? You can either use the microphone to ask Adel directly. There is a smiley face on the right side, the box underneath the video, so you can click and raise your hand to ask questions. You also can ask questions by text, applying text. So please feel free to ask for the mic, give you the mic to ask your question directly. And while we're waiting, Adel, so did you calculate the actual STS risk score for her? I know you said the aortic root was calcified, so it's going to be challenging, but did you go and do this math and decide what number is high enough for her not to go to the OR?
The good news for this lady, if you look at the root chart, the aorta was not calcified, the root was fine, they could work with it. The problem was the access, the peripheral vascular disease, which probably Dr. Mehiar will mention, we'll talk about. My dilemma was access. How are we going to establish cardiopulmonary bypass in this lady? Initially, when she came in, she wasn't intubated, and those are the kind of cases that could crash, and sometimes you need to expose them to local before you actually induce them, because when people come to you with temper, these are the ones who could crash easily on induction. So, crash, when you have a fresh heart, having been opened before, is okay to deal with quickly by opening and doing telemassage and try to cannulate while you're. But to crash, when somebody has a lot of adhesions and redo setting, and to establish cannulation by femoral, and that was clearly demonstrated by the intervention cardiologist. I I was frustrated by the numbers of folks we made in both groins. We couldn't get any drop of blood back. So when we looked at the imaging, and we saw the look of the descending aorta and the peripheral vascular disease, and it's all eggshell, calcium everywhere, I said, well, I don't think surgery should be intervened. That's what pushed me to that.
Right. So mainly the axis that made you kind of more concerned about her. Now she was essentially in a state of shock. Like blood pressure was 100. So based on the guideline you showed, maybe some people will feel more like she's kind of more frail. Although the pressure gradient was only like what was 40 as a mean. So she's in the moderate to severe range. It would be nice to see the echo. Echo may show some more, because I don't know how you're going to size the thrombus based on the recommendation.
She also had at least 3 plus AI, so she does also at least 3 plus AI. I do agree. I think if this patient was 40 years old or 45 years old, with no other severe COPD and all this other immobilities and multiple falls, and the more we talk to family, they don't. I mean, reach to a degree where they tell you, if my mom was sitting here with us today, she would absolutely not have the patient wishes, the patient profile, the patient risk. If this patient was 55, 40 years old, for sure I'm going to take to the OR right away. I will be doing axillary cannulation. I'll be cannulating the femoral vein. I'll take whatever it is, because sometimes you just have to do it. And we've dealt with these people where you have to really go fast. Axillary would take probably 20 minutes to do, not like the femoral, but you would cannulate femoral vein to establish bypass and axillary, and then you go on bypass, and then you're happy, and then you hypernize and everything, which is fine, and do most of your dissection in the blood surgery. But I just felt, because we've had other modality of treatment in the context of her age, in the context of her risk, in the context of her pre-morbid condition, I think this lady was looking at higher risk of operative mortality and unstable mortality, and after long in hospital, given that that's usually probably
right.
Setting of 80 years.
So, any more questions? I think there's a comment from. So, Dr. Sami Query says femoral vein, subclavian, axillary, the same exactly as you described, although it's time consuming. Dr. Haytham Bunaya said to assess mobility and the size, probably TEE would be better. Yeah, I agree. Except sometimes shadowing also may be an issue. Right. Although sometimes shadowing is an issue, but again, if it's a thrombosed valve, I think fluoroscopy may, Yes, Adel?
Looked at even I presented this case about cardiac CT in relatively stable people. With cardiac CT would help to determine the size of the thrombus, presence or absence of pannus. Because I think the question is, if you look at my first slide or the second slide, the presence of pannus is almost about 60%, because if you look at classification, it's purely thrombus only, pannus and thrombus, and pannus only. Having pannus in place, you definitely would jeopardize the success, or make the thrombolytic therapy is either raise risk of recurrence, because you could have a success, but having the pannus in place may actually promote more thrombus later on. So I think, I'm not sure if a CT will give you more information, more details as to the presence and the size of the thrombus and the presence or absence of.
Yeah, do you know, Adel, why?
Experience with CT in the setting of thrombosis. These are usually very sick people. They come on a weekend or at night.
Yeah, that's a good question. I don't know if there is anybody in the audience who is has experience with CT. I don't know. I think if somebody can weigh in for this part, it will be interesting. And while we're waiting, Adel, so a couple of questions. Do you know she had a colonoscopy? Was that a routine colonoscopy, or was it because of bleeding issue? Because the question, I think, now going forward, what's going to be your next INR dose for her? Like, what's going to be your next INR target for her, since she have now thrombotic event? And also, what's her bleeding risk? Was that colonoscopy just a routine colonoscopy, or was it because of bleeding issue, which then affects the the long-term anticoagulation status. So this is a question. So do you know the answer to those?
Yeah, I think for the colonoscopy, she looking at her. I think when you look at the CT abdomen, I'm not surprised that she has some sort of sinus ischemia. So I think she according to her daughter, her mom, has been complaining of some chronic abdominal pain. But I have a feeling that when she came 2 days ago, the sudden onset of abdominal pain, AFib, because for 12 days, I think she was put on hold for Coumadin. And when even she finished the bridging for the colonoscopy time, she was asked to go back on Coumadin. She didn't take it. So either she threw a clot and she caused some miscarriage and didn't show anything in the appendix or any report of any clot in the heart. But I think there is a component of AFib, subtherapeutic INR, inadequate bridging during the 12 days prior to this. Colonoscopy, I think, was done for chronic abdominal pain. Was scheduled, was outpatient, and done, went home. And this lady, as I said, she's not a very reliable with her medication. And the daughter tells me, I'm not sure if my mom even come back on Coumadin because at presentation her INR was 1.2.
1.2. So there are some comments. Yes, Adel. So there are some comments. I think if you can go over them. From Dr. Haytham Bulmaya from the US, he said, I will be concerned about the same issue with the CT. So there's shadowing around the mechanical valve. So, and Dr. Haytham Bulmaya has expertise in imaging. I know that. So that's a good comment. Dr. Nadia Sidney from UK, she made a comment or asked a question actually, how long after thrombolytic would you wait to assess response? And if no response, that's a good question, after thrombolysis. Panis would be a major thrombus. Surgery would be exactly, I don't know what's, I could read, should be in consideration or contraindicated. So,
well, it is brought up. I would answer the question by Nadia. Nadia, she's my colleague. She was my classmate
a
long time ago. It's a very interesting, smart question as usual. I think if you commit yourself to thrombolytics, I think in this lady, our threshold for taken to the OR was close to 0 or 1, which was agreed upon by the family. I do agree, if we do thrombolytics, you should see response within a few hours. In this case, we saw the response within a few hours. It was given at 2 o'clock in the morning, but by the time I rounded at 7:30, 8 o'clock in the morning, bedside echo was done around, I don't know, I mean, she's already, you can see the levopred dose was like only 2 cc, was already a requirement for inotrope was less, blood pressure over 100. So I think if somebody who will be probably, you think that you're going to take him to the OR, I think if you, somebody thrombolytics, you're thinking at least an hour before you take him to the OR. Otherwise, some people with thrombolytics on board, you just have to enter the blood bank. That's basically it.
Any more questions?
7 again. Not the surgery that you.
Any more questions? So I think Adel, from practical standpoint, going forwards, what's going to be the new targets for anticoagulation? And this is actually a question for everybody in the audience. If this is your patient, I'm going to ask the audience, if this is your patient, what's going to be your next target? Is going to be 2 to 2.5, 2.5, 3.5, 3.54. So what's going to be your next target, since this is somebody who had the thrombosed ones? And I'm sure, Adel, you will have some future follow-up on this patient to see her compliance.
I would say for this lady, we did 2 things. First of all, I think this lady was poorly managed by, not poorly managed, but I don't think it was a good follow-up when although she's a family that she's been bridged and this, I don't think lately in the last time and the last event, she was very good with and was compliant with her. I think it is due to inadequate anticoagulation. This valve she lived with for 20 years. So I wouldn't probably change my threshold, but I think what I did is I hooked her up with our thrombo clinic, and I know our thrombo clinic are very, very thorough, and they monitor, they call, they're very, it's unlike when somebody's a mechanical valve, only family physician is following him, so at least for the acute phase, 6 months or so, until they get her back to what she was before. And I don't think I would need to change our the target probably, I mean, she's frail, she's old. I don't think I want my INR to be 3.5 or something. 2 to 2.5 would be probably okay. It's the aortic position. It's imposed because of a reason, because she hasn't taken her stuff, and that's my take.
Okay, so maybe either just to finish up your case, put this poll for the audience, question for the audience. If this is your patient, and this is what happened to her, so these are the different INR targets. So you have about 4 choices. Go ahead and select one of those choices. Let's see people here, what would they do if this is their patient? So which one of these would you choose? And go ahead and vote, please, and then press vote and press answer, and then at the end we'll get the result of all these votes. Let's see the result. So most people, based on today's attendance, they will shoot for 2 as INR targets. That's very interesting. Great case, Adel. Any further questions? If you have questions, you wanna. Anyway, we'll open the case again toward the end of the meeting after Mehiar's presentation for discussion. If somebody has forgot a question or anything, we can go ahead and do that. Thanks so much, Adel, for this outstanding presentation. Now, next speaker would be Dr. Mehiar El-hamdani, my friend and colleague, interventional cardiologist. Mehiar is going to educate us about the peripheral coronary intervention, and he will present some short cases as well about peripheral intervention, so that's going to be very exciting and interesting. Mehiar, the floor is yours. Go ahead, Mehiar.
All right, thank you, everybody. Thank you for having me here. It's my pleasure to go over a few things here today. I'm going to really goal for this talk is basically raise the awareness of peripheral arterial disease. Maybe we will start a little change. We'll start with some cases, and then after that we will go over the slideshow just for the sake of time. Anyway, so what we need to do is basically try to really understand and correlate peripheral arterial disease to patient care as any other disease. So we tend to have always tendency to think about coronary artery disease, to think about lung and cancer, etc. So this is the first case. This is a 68-year-old VA patient, COPD. He's on 3 liters of nasal cannula. So as you can tell from this picture that this guy has a total right external iliac artery, common iliac artery, but relatively very good, reasonably good SFA, popliteal, and 3 vessel runoff. On the next image, you will see almost identical. So really, as you can tell here, you lost the external iliac artery, you lost the common iliac artery, and then, again, you will notice that the common femoral SFA, although there's some disease, but relatively fine popliteal artery, and then a 3 vessel runoff. This picture, as I came from the brachial artery, and as you can tell, the aorta is almost 100% occluded infrarenal. So below the renal arteries, you don't have any flow to the aorta. So this guy ideally should go for axillary femoral bypass with fem bypass. So they take one of the axillary to do one of the femorals. They do one bypass on one side, and most likely they will do fem to fem bypass on the other side. But this guy is, as I said, he's a COPD, diabetic, 67, young in terms of age. But axillary fem and fem bypass combination by itself is a very high risk procedure with a mortality rate approaching 10%. When it comes to somebody who is on a 3-liter nasal cannula, that's going to be a major surgery with a high mortality rate. So I was approached to see if I can help this patient, and then I went ahead, and as you can see in this picture where I stopped it, I already reached to some point in the aorta distally, where I can, in a way that or the other, I was able to push 2 wires from each side. If you remember, the picture was really total occlusion of the external iliac and common iliac, and I stopped there, and this is where I took another picture to see if I am really close to where I want to be. From there, it's probably a little bit easier, where in the next pictures, you'll see that I was able to cannulate and start doing ballooning from each side and then in the aorta itself, and then simultaneously putting some stents in the aorta, and then go down to the rest of the territory. I mean, really the major thing is that recanalizing the aorta with its all dangerous situation. And then, the rest of it, it's really just stenting and ballooning and recanalizing. And as you can see now, the right side, some dissection there with some clot formation, but taken care of eventually. And now just, basically cleaning up the mess, if you will, trying to create, a better picture. So this guy did very well and was discharged the next day without any further issues. Long term, I lost actually follow-up. This was done in 2009. I don't really have a follow-up on the patient as he is referred to us from the VA Medical Center. So again, I mean, this is a very just quick case. We can go to the next case. Fathi, this is just a repeat of whatever we did. The next case is a lady who's 57 years old, who really has no history of diabetes. She's just a smoker. She has a hyperlipidemia and family history of coronary arteries, peripheral arterial disease. Patient basically had a bilateral total iliac artery stenosis. Ideally, these are, again, a high-risk classification with the TAS classification. Ideally, you should go for a bilateral aortofemoral bypass. Simply, patient refused. She said, I will do it. I took the leverage to just go ahead and be aggressive with her, and I worked on her right side first. I was able to recanalize that to the aorta. And then after that, I believe I stented on the right side. And then looking the stump on the left iliac artery, and you can see how the external iliac artery is trying to recanalize from above, and then could not get through it. I tried to canalize from below, and I was able to, after using different maneuvers, and actually there are some tools that we can use to help to get through the lumen, which I was able to get through the lumen, and then the rest of it is really easier, where you just have to balloon and stent the right common iliac artery as well, and create the carina of the aorta, and after that it's easy task. This lady actually did very well, and usually stenting the iliacs and the aorta really has a very good outcome, even with stenting, if it is doable for a long-term outcomes. Next case. This is another case where there is just a called straightforward, simple SFA, very short, if you will, blockage in the SFA, total SFA, recanalized with some collectors in a patient who does have a limiting coagulation, and that was done just by wiring, ballooning, and putting a stent in the area. Patient did very well again for quite a while. Next case, please. The next case will be a little changing here. So I'm going from aorta to iliacs to SFA. Next case, please. This is a little different. Now we're talking about a guy who is diabetic, hypertensive, hyperlipidemia, who does have a very limiting claudication, no ulcers or anything like that. And, as you can tell from this view, this is the SFA popliteal coming down, and then your anterior tibial artery is 100% occluded, and then really you have a very tight, about 95, 99% stenosis at the tibial trunk, and, there is no posterior tibial artery. So the patient lives only on this deep peroneal artery. For his symptoms, all these patients, of course, has to be treated with minimum, I would say, celestazol for therapy if they can tolerate, and with, among other, risk factor modification, aspirin, and also antihypertensive, good diabetes control, and also cholesterol medicine. Nevertheless, he's symptomatic. So in this case, I went from both pedal axis as well as from above. So I came from above with a wire, and I was able to wire through the tuberperoneal trunk to the deep peroneal artery. I was able to access to an ultrasound guidance the distal part of the posterior tibial artery, and this is the only thing that he has, just very distal up above the ankle, where I was able to go backward, and as you can see, I was able to recanalize with the wire, and my wire is up in the SFA. Now, in this view, you can see that there is a balloon coming down from the antegrade axis, meaning that popliteal down. And you can see here there's another balloon that I was able to put from the posterior tibial axis going up. And the concept of kissing balloon in parapopliteal is not well known in the peripheral arterial disease, has been well known in the coronary and in the iliac territory. So anyway, I mean, from that point, again, I mean, always wiring is the worst, problem. But then after that, once you wire and you're really in the human, now I ballooned from above and I ballooned from below. I did what we call as a kissing technique here. And then on the next picture, you will see that I ballooned the posterior tibial artery, because as I said, you can see that there is severe disease in the posterior tibial artery. So I ballooned the posterior tibial artery, and then after that, I took a angiogram from above and below. This is the angiogram actually from below, so the posterior tibial artery is all open, and actually you have a little dissection there. As you can see, we don't care about dissections much in the peripheral unless they are flow limiting. In the next picture, you will see this is coming from above, now from above popliteal, and then you have, of course, the deep peroneal and the posterior tibial. Of course, the anterior tibial is 100%, and there's no need to chase that, as the patient doesn't have ulcers in the foot. It's just the claudication symptom. On the next case will be an older lady with diabetes, hypertension, hyperlipidemia. This lady has an end-stage renal disease on dialysis, and also she has a huge ulcers, both in the heel and the medial as well as the lateral aspect of the foot. So this lady, as you can see, the popliteal artery has a very tight disease, about 80 to 90% stenosis. And more than that, you can see here that the anterior tibial artery also starts and has a tight stenosis at the proximal segment of the artery, and then diffuse disease. And actually, and I'm not sure if I have it here or not, but hopefully I have, it's actually 100% occluded after that. And then you do have the tuberperoneal trunk that has a total 100% occluded posterior tibial artery, and then the deep peroneal artery itself has a tight lesion over there. Let me play here the YouTube to see where we have. So in a way, what I did with this case, actually, let me see this picture here. So this gives you probably the whole territory. As you can see, I'm going to stop this for now. So really, your anterior tibial artery is really vanished after a certain, length, and your posterior tibial artery is also, has severe disease. A deep peroneal artery. Posterior tibial artery, as you can see, it's 100% over here. So this is the only, left from the posterior tibial artery. So in this case also, when you're dealing with this critical limb ischemia, as we call them, people with ulcers, you just have to be very careful. You have to map your leg very well, both angiographically and with ultrasound. So I brought the ultrasound, and on the next picture, you will see that, I was able to access with the ultrasound from below. This is just showing here here we go, this is the one. So now, as you can tell here, I was trying to get access to the artery from below over here. And this is basically my wire going up there. Now let me play that back, because, what you saw earlier is really the shadow of the bone rather than the artery. So what you see here, this is the bone shadow. This is not the artery. The artery is really here. So the wire is going to come up there. I'm not sure what's happening anyway, but I was able to do what we call as a CSI, or let's say it's more of a rotational atherectomy from retrograde to the anterior tibial artery. And I did that actually. I went even up and down the deep peroneal artery, and I did the proximal segment of the deep peroneal artery, or to the peroneal artery. And you can see there is really significant dissection that I could not leave alone, where I used a coronary stent that I put here. So now this is a case that it is a limb salvage critical care with severe ulcers you have really to secure significant blood flow. Otherwise, whatever you do, it's not going to be counted. So at the end, we have a reasonable popliteal artery flow, and we did have a reasonable, anterior tubular artery. I do have even pictures of this lady healing process that I did not include in this talk, but it's really a very rewarding process. The next controversial case again, go to the next case, please. Next case, this is a guy that, interestingly, he had a big and second toe gangrene, and actually septicemic with active bacteremia. They called vascular surgeon to see him, and the vascular surgeon said that the risk of graft infection will be very high. I would rather not to mess up with the guy. They called podiatrists to really amputate the big toe and the second toe. Podiatrist said, without adequate vascularization, I wouldn't be able to do that successfully. Maybe healing will not be enough. As you can see here, really, you do have some collaterals. There's a prosthesis. Sorry for that, but really, there's no popliteal. There's nothing here. There's no SFA. Hopefully, on the next picture, you will see more of that. So this is just a picture that's showing, what do you have in the distally. This is now a retrograde approach to the posterior tubular artery, and as you can see, the posterior tubular artery goes and stops somewhere here. All those that you see that are just collaterals. And again, the prosthesis comes in the middle here, but you will see at the end of the case. And you can notice that there is no deep peroneal artery, there is no anterior tubular artery. And from above, you will see that the femoral artery, this is the profunda, this is common femoral artery. The femoral artery really stops here. There is just a little knob there as it starts, and I have a catheter there. Because I'm starting my intervention here. So I decided to go and intervene with this case, although this is definitely not a intervention case. So here I ballooned and it just came very quickly. So I was able to wire, and the way how I wire these cases is that I go from both sides. So I try to wire from above, then try to dissect and move on with my wire, and then try to go from below and, chase my way up and meet somewhere in the middle with two different catheters, and then usually, if I am in the right plane, I will be able to really communicate with my wires, either from retrograde or antegrade, and go from one catheter to another until I pull the wire from the other side. And this is what I did in this case, actually. And I was able to, balloon, as you can see, and then now I have some flow in the right SFA, as you can tell there. And now I have, some stents put in, and as you can see here, this is a very important case where, most of the SFA is reasonable there. But, here I stented, and of course, as you can tell that I'm going through the dissection plan, and now I'm creating a little bit hassle here with some dye leakage from the stent. So I know that this may not go well if left alone. Nevertheless, I was happy the way that the popliteal. This is showing you that the proximal segment for that knob of the SFA, this is the profunda here, this is the SFA. I have to stent that, and this really, you can tell there is a very good flow going down to the SFA. And then, from there, I'm going down there, and I put stents across that leakage. This is a Viabond stent over the already stented area. So this is where that leakage at, and down the next picture, you will see the proximal segment of the SFA stented with just a normal type of stent. And then, this is the distal part. And now, you can see I pulled my sheet from the posterior tibial, and this is where usually I access, and maybe this will be the access side, and it's really very healthy and have a very good flow. The good thing why I'm presenting this case, not because, I'm, Superman, I can do it, but these, they don't last long. So, you're just trying to serve the patient for the moment, for the healing. And guess what? He still has his toes. The big toe is still there. The middle, the second, the toe is still there. Healed completely. But he came back after about 6 to 8 weeks with the thrombosis of the Viabond stent. The Viabond stent is a type of a covered stent, and they do have a tendency for thrombosis if you don't start them on anticoagulation. And you know, there's no recommendation for anticoagulation in those stents. But he came back with thrombosis. At that time, I tried to do a laser atherectomy to clear the thrombosis, and I used even a TPA to clear it. It didn't clear much. I called one of my friends, Dr. Mehiar, who does some vascular bypass. So he did bypass, but now he can do it because he does have a good clear flow in the posterior tibial, and actually he was able to bypass at the site where the stent in the proximal posterior tibial. And this has been about a year and a half, and I just saw him about 3-4 weeks ago. He have a very good flow, and he's a farmer chasing his chicken every day, doing a very good job. So this is the cases, and now if we go back to the presentation, please. Okay, I'm going to answer the question first from Dr. Sunni. Could you please comment on some of the equipment you use, especially your guide wires and balloons? I have found some of the interventional vascular radiology equipment useful for difficult cases like this. Okay, and Dr. you said, what is the routing antiplatelet and or anticoagulation after peripheral stenting? Great. So the antiplatelet therapy is merely aspirin for life and Plavix for 1 month, but you're just using balloon and using a bare metal stent or non-eluting stents. If you are using drug-eluting stents in the periphery, which there's few out there now, you have to go for dual antiplatelet therapy for just 2 months, and then just aspirin by itself. For Dr. Sunni, this is a very good question. I love the peripheral business just because it's full of imagination and creation and innovation. There is no set of rules, what do you use and what not. In the coronaries, we found ourselves there's a lot of guidelines and there's a lot of standard, if you will, of how you do things, whether you're going to do a kissing or no kissing, whether you're going to do conventional therapies, etc. The peripheral is really open. It depends on the resources that we have. It depends on the skills that certain people they have, and also the acceptance of the institution that you practice in. These are very important. They have all to be together. Otherwise, you really can't be as aggressive as some institutions, etc. What I use usually for complex cases like this, where I have to go from above and below. So first of all, let me just talk briefly about pedal access. Pedal access never should be the initial approach. You have always to start from above. You have always to start from the usual femoral access, whether go up and around the aorta or antegrade access, but that should be your first intention. In very few cases where you probably, after you've done so many of those, you can plan your case and you know what you're going to do, and then you're going to do a pedal plus, a femoral access. But let's say that you're going like these cases where you go pedal access. I found, and there's so many wires, so many techniques, but I found the best wire for below infrapopliteal anatomy is what we call the regalia wire. Regalia wire is very good if you're dealing with CTOs or subtotal lesions. If you have a long CTO, I found that a stator wire is probably very good. There's a stator 20 grams and a stator 30 grams. Stator 20 grams are good for infrapopliteal. The stator 30 grams are good for SFAs and iliacs. But these are very dangerous wires because literally they can go anywhere. You push it, it will go. So, a little three-dimensional imaging, four-dimensional will be much better in your brain, where, and definitely there has to be some complications that happen in the past where you can really redirect yourself and know and learn from your own mistakes, but it is very challenging. I tend to use catheters a lot with my CTO's, intervention. I deal a lot with the Navicross. There's a straight and an angled Navicross. They do have torqueability more like, like a wire. So you can sometimes even create a little dissection with these Navicrosses. And then, you can take with the wire the rest of the case as much as you can. You know, using hydrophilic regalia, it does. The tip of it is a hydrophilic wire, but the rest of it is really very stiff wire. It's more difficult to go radial with longer wire. You know, I do have actually, which I'm ready to submit the case series of 4 cases where I did pedal radial interventions in a way that all these cases that they don't have common femoral, they don't have iliacs, so I don't have a way to do it except that I go from the pedal and I come from the either brachial or radial, and the 4 cases that I have is radial pedal. It is very difficult. It's not because of the wires as much as of the you know, the length, you know, of your equipment. Most of them. From the radial, you probably can reach to the common femoral artery. From the brachial, you probably can reach to the distal SFA if possible. So I'm going to go. I mean, you guys can write, you know, your notes and comments. I'll try to really, you know, answer them as much as I can as I read them. So feel free to do that. So peripheral arterial disease, as I said, I mean, there's no disclosure, but, you know, my goal is really change the awareness and really fuel up, if you will, the gas where we have to be very aware of our disease and peripheral arterial disease. Why we care about peripheral arterial diseases? We care because it's a major cause of acute and chronic disabilities. It limits the functional capacity, impairs quality of life, and also major cause of limb amputation, which I hate. Marked increased risk of non-fatal cardiovascular ischemic events and MI, strokes, and death, and early detection and treatment decreases risk of MI and stroke and death. So there's no brain. It is a very important. So this slide will show you the prevalence, and it's so common and interactive with other problems like CVA, cerebrovascular accidents, and coronary artery disease. More interestingly, in this slide is that, you know, those people that you see at the bottom right running in the park, those, if they do have PAD, they are at risk of all what we talked about. I mean, they still you know, have a major issue, and this is really the interesting part. So carrying the diagnosis of PAD by itself is a problem, whether you're still functioning or not. And we have to really switch how we think about it, because we've been for years thinking that, oh, okay, if you can walk that many miles or you can jog that many miles, you're okay, you're safe. No, they're not okay, they're not safe. They are just functional, but they carry a lot of other risks in terms of cardiovascular events. So this is where the issue starts. So the prevalence in the United States, you know, think about it this way. We care so much about stroke, and it's only about 5 million. But, you know, you have a double that in peripheral arterial disease and close to what you have in coronary artery disease. This is one of the landmark trials that done on the prevalence of peripheral arterial disease, and you go to the partners at the bottom of it, has about 30% prevalence in the population. Most of those had combination between coronary artery disease and peripheral arterial disease, and about 56%, and about 44% they have only peripheral arterial disease. But this is very important, you know, aspect. When we come to the prevalence today, there's no brain. I mean, the longer you live, the more chances that you have cardiovascular diseases in general, but peripheral arterial disease seems to be really very problematic as we get older. And in terms of female to males, it's similar to coronary artery disease. I mean, the younger the women, they are more protected. The older they get, that protection goes away. Be close to men, and actually, you know, more than 85 years of age, women has tendency more than men. But you have to remember that also women, they live longer, so maybe that's part of the equation. In the San Diego population study, they found that blacks per se have are an independent risk factor to develop PAD, despite of their diabetes or hyperlipidemia. It doesn't matter whether they're diabetic or not, or hyperlipidemic or not. Just being a black, you carry a more risk to develop peripheral arterial disease. And also diabetes, as any other thing, it's really the chronic death in our society. Just look at the difference between just having a normal glucose tolerance. The prevalence of PAD is about 12%. That almost goes to, almost close to doubling just by impaired glucose or by diabetes itself. The funny part is that, or the interesting part is that, you know, being an impaired glucose tolerance and diabetic not make a difference. So you just need to be an impaired glucose tolerance just to have a peripheral arterial disease risk. That's really very scary to me. You know, risk factors that are synergistic. Smoking, as we know, is the bad one, especially in relation to peripheral arterial disease. And for those population that has a normal blood pressure, normal serum cholesterol, look at the difference between smoker and non-smokers. It's almost 3 times. It's actually 3 times. It's from 0.8 to 2.6. If your blood pressure and cholesterol are not well controlled, again, it's almost 3 times. You know, the risk goes high in those population compared to the baseline or compared to normal people, but smoking is synergistic. And again, that goes higher if your blood pressure not well controlled, actually poorly controlled or uncontrolled, and when you have the worst familial hypercholesterolemia, then that risk go high. And if you smoke on top of that, again, it's almost 3 times the risk. And then, you know, these are the traditional risk factors for atherosclerotic disease, but in the peripheral arterial disease, smoking, diabetes, and hypertension tends to be really the strongest. And of course, we had hypercholesterolemia, hyperhomocystinemia, and C-reactive protein. I don't think that they will, you know, be important in your management, but they are more of a association rather than a causation. Cardiovascular events and PAD. If you have a patient that has a PAD, the risk of stroke increased by about 3 times, 4 times fatal in mice. Death in general from cardiovascular events goes to about 6 times. But that's why those people who are running and jogging in the park with a hidden peripheral arterial disease, they carry this kind of risk. Of course, this risk is for symptomatic people. But if we go to people who have the diagnosis of peripheral arterial disease, whether it is asymptomatic or symptomatic, and you go and see, this is male and female, go and see what's their risk of having a myocardial infarction and death. And look at the jump that happens between no history of PAD to history of asymptomatic PAD, meaning jogging every day in the park, to being symptomatic PAD. I mean, there is really no difference whether you are symptomatic or not in terms of cardiovascular event. It's so close to each other, and that's in both races, male and female. This slide is just blow off everything. If you look at this slide, people that had, this is for long-term survival, people who are normal subjects, they live long and they live normal expectation of life. Once you do have an asymptomatic PAD, look at how much the drop. It's approaching 50%. So life expectancy drop by at least 40% from normal population in asymptomatic PAD. If they are symptomatic, it goes beyond that. And if they have severe symptomatic PAD, meaning that they might have an ulcer, unhealed ulcer, etc., that goes tremendously. This is only in 10 years lifetime. Actually, that, if you go back, that starts from about 2 years. And in 5 years, you know, you have significant drop in life expectancy. To me, this is crazy. I mean, really, this is something that, this is where I love PAD. This is where I'm really interested in this subject and why I'm doing much of my cases nowadays. It's really peripheral arterial disease. So, okay, am I still connected? How about, you know, just doing an ABI? If you just do an ABI, whether your ABI is abnormally high or your ABI is abnormally low, your risk, 5 years risk of coronary artery events goes high, as you can see, by 2% and 3.8%. This is per year. 5-year risk about 10% and 19% respectively in these kind of normal ABIs. I'm talking about just 0.7 to 0.9, which is, if you do that nowadays, if you have a patient that has a 0.87 ABI, say, oh, it's okay, just walk and don't worry about it. I agree, and this is what we should do. Don't worry about it. I'm not talking that we're going to, you know, test everybody and do angiogram and put stents, but I'm just saying that the awareness of the disease has to be raised into a very high level, where when you're sitting, taking a history and physical examination, you don't feel the pulse, or there is a symptoms of claudication, and you send that patient for ABI, your awareness of that patient's survival, that patient's complication, should be raised to a higher level more than what we are doing right now. And maybe some of you are doing it, or all of you are doing it, which is great. This is comparing that survival, like we compare the survival not with ABIs, just by symptoms. Now, compare the sim survival by ABI data. It's the same thing. Look at what happens in 10 years if the ABI is 0.4. You're losing your patient. Most of you, if you have 10 patients with an ABI of 0.4, the chances of them will die in 4 years is more than 50%. The chances of them that you lose your patients just based on ABI, based on PAD, in 10 years is exceeding at 70%. So 7 of those 10 that you've seen that will die in 10 years just because they carry this nature of, beast of disease. And in 4 years, about 60% of them, they will die. It is really very significant data. So the natural history of peripheral arterial disease, I mean, again, I highlighted the important things. The critical limb ischemia is very important. So in any population that you have, with peripheral arterial disease, about 2% of them, they would have clinical limb ischemia. The rest of them, they will not, but we talked about their risk in general. And 25% mortality in 1 year. So whenever you see a patient that has a diabetic foot ulcer that is related to ischemia, you know that there's a chance that that patient will die in 1 year. And this is really crazy. If you take those people and not the critical limb, just take the people who are either asymptomatic or symptomatic. Out of the country, out of what we think, most of people, they have atypical symptoms. It's not typical, claudication. So the majority, they will carry atypical symptoms. But regardless, 5 years outcomes. Look at this. Look at that green here. Now we're talking not about critical limb ischemia. We're talking about people that they have either asymptomatic PAD or symptomatic PAD, whether it's typical or atypical. 5 years outcome, about 15 to 30%. Let's simplify. 20% of them will die in 5 years. And of course, you have a stable claudication about 70 to 80%. But stable claudication is in terms of symptoms, not in terms of mortality. So amputation is not a treatment. I mean, I see amputations so often, and I just don't like it. Amputation is a management failure. When we fail to help the patients, we go for amputation. You never allow your vascular surgeon, and there's a great vascular surgeon everywhere, and nowadays most of them are interventionists too, which is very good. Try to make your best to keep that limb for some time, because I will show you what's the difference in that. So complication, there's a lot of complication after amputation. I'm not going to go into that, but perioperative mortality, just going through the surgery, reported to be as high as 40%. Just cutting the foot, what's a foot? Nothing. Just cutting a foot, perioperative mortality is about 4.5%. Cutting below the knee, 6.5%. Amputating above the knee, it's 14.5%. This is talking just perioperative mortality. We're not talking about anything else. Of course, most of this are from MIs and cardiovascular events, but still, it is a perioperative mortality. If we take amputation and a long-term follow-up of amputation, look at this graph. Look at the graph below the knee and above the knee, and look at what happened in 1 year. Look at your survival, about 74%. And 50% if it is below the knee in 1 year. You're losing 50% of your patients in 1 year after above knee amputation. In 5 years, you're losing more than 75% of your patients. If you have 100 patients that you said, okay, I'm going to do amputation above the knee, you're going to use 75% or more of those patients in about 5 years. And of course, it goes below as you go. And I think this is very astonishing. I mean, this is, to me, so scary, and we should not do it that way. I think I lost some of my slides. Okay, here we go. I'm back. So, and this is just, I found this in one of the meetings that I went to, and it's called disease awareness. And look at the prevalence. If you talk about multiple sclerosis, you will find, and they did this study, this is a study that was done. They found that there's about 300,000 cases of multiple sclerosis. And the awareness of the population about multiple sclerosis is about 42%. Similarly, if you talk about cystic fibrosis, there's about 30,000 cases of prevalence of cystic fibrosis. Here in Huntington, West Virginia, a population of less than 100,000, do have a cystic fibrosis clinic in the university. So in 30,000 prevalence, 29% of the population are aware of a disease called cystic fibrosis. We have 10 million peripheral arterial disease prevalence. Only 20, actually this is a typo, only 26% of the population, less than even the cystic fibrosis, 26% of the population are aware of the fact that we do have a peripheral arterial disease and it is really a nasty disease. I created this slide by myself where if we take stage 3 breast cancer, so stage 3 breast cancer compared to stage 3 colon cancer, and I will have to define that in a minute, comparing to PAD, and to above knee amputation, below knee amputation. Look at the difference. Stage 3 breast cancer survival rate is about 73 to 74% in 5 years. Stage 3 colon cancer, if it is stage 3A, the survival rate is about 75%. If it is stage 3B, the survival rate is about 67%. So about 70% in general survival rate of a stage 3 colon cancer. The survival rate of having PAD is about 70%. But if we tell somebody that you have if you receive a phone call from the radiology department saying that your patient had a mammogram possible of a breast cancer, the whole office is going to go crazy, and it's like a state of emergency because it's a breast cancer. Or if the GI doctor did a colonoscopy and took a biopsy, and now the biopsy came back as there is a cancer. Again, it's in a state of an emergency, not only as a physician, but the whole system will create a state of emergency to take care of that patient because this is a cancer. Peripheral arterial disease carry the same, if not worse. Peripheral arterial disease survival rate in 5 years, in general, we're talking about 70%. Look at above knee amputation. Look at below knee amputation in the yellow and the orange markers there. That's devastating. Yet we still tell our people, oh, it's okay, it's just, cut limb, that's fine. Or you're taking a history and you're admitting a patient or whatever it is, or somebody's calling you and tell, oh, he does have a below knee amputation. I feel, maybe not everybody, that in the past, this information just goes like this. Oh, okay, he has a below knee amputation. Okay, thank you. Or he has a above knee amputation. And I think we need to change that. When we hear these terminologies, we have really to think deeper than just being said. So the pathophysiology, it's an engine, as you all know, and it's just a combination between basically a demand ischemia and lactic acid accumulation, which create the pain. But there is something that's very interesting in the literature that's not like 100% proven. But I want you to think of this like the remodeling of the heart when there's a heart attack. So we try to open the artery, we try to, if we can't open the artery, to talk to our surgeon to do the bypass quickly, etc., etc. And our goal is always, we don't want that remodeling of the heart muscle to start. We want to prevent remodeling. We want to delay remodeling with medications. We want to prevent modeling with revascularizations and medications. Guess what? There is a remodeling. We just don't call it remodeling in the peripheral arterial disease. Decreased type 2 fast twitch fibers leading to muscle weakness, and if it is prolonged, can create progressive denervation, and it's too late then. Maybe there is no need to do anything. Hopefully not, but this is an issue. I'm going to stop to read some of the comments because I don't want the comments to be really forgotten. And forgive me if I'm slow. Dr. Sunni, does any I know where we as Arabs, Middle Easterns stand with atherosclerosis? Here in UK, there is a separate entity for SE Asian coronary disease that is well established regardless of diabetes, hypertension, and cholesterol. I don't know the answer for that, but you're absolutely right. The Asians, they do have a different standard for that. Dr. Adel, I think the answer depends on where they reside. If they come to North America, the risk will go up due to change in, that's definitely. But remember that the westernization is going everywhere. I don't think that there's now called the western and eastern. I mean, probably there's more disease in the eastern side of the globe more than the western side, just because we all want to be like America and the western in general. But fixing PAD will not change survival. PAD may be a marker of mortality rather than because love your talk. Thank you. I agree 100%. You know, what you're creating with the, I'm not here promoting therapy as much as Khalid promoting disease awareness more than anything else. But that, yeah, the therapy is totally different. And that's not the promotion, but thank you for your comment. So we move on. So again, if you think about it, I mean, you know, simple terminology. So if you're dealing with a heart failure patient, I mean, dealing with a PAD, symptomatic peripheral arterial disease, it's like dealing with a New York heart 3 or 4, you know, class 3 or 4 in congestive heart failure. This is exactly the correlation of it. So the obstruction can be anywhere in the anatomy from above to below, and we dealt with those in the cases that we presented earlier. You know, as I said, there is typical and atypical, and you be careful of the atypical because they are really more common than the typical claudication or leg angina in general. And you have to be aware of the differential diagnosis of this. So common differential diagnosis will be venous, you know, symptoms, and usually the sense of tightness and claudication that improves by raising the leg and wearing a, you know, elastic socks, etc. But the other one that is very common is spinal cord stenosis, and typically, you know, somebody will have more symptoms as they are walking downstairs, and that relieved as they are going upstairs, basically reflecting on the extension and reflection of the spine. So defining population, so, you know, you're going to say, okay, going back to what Khalid, Dr. Idris question. So going back to, so what is what? So our goal is usually recognize these people ahead of time before it's too late. Because when you recognize them early, then your intervention doesn't have to be catheter, doesn't have to be a stent, doesn't have to be balloon, but hopefully prevention. And the prevention can be by exercising regularly and eating right and taking the right medicine. So you have to define your population at risk. And those are age 70 years and older, age 50 to 69, but they do have either smoking or diabetes history. If it is than 50, it has to be 2, diabetes plus any other traditional risk factors for atherosclerosis. And then non-coronary artery disease, carotid or renal artery disease, and also leg symptoms that's typical for claudication, or we think it is claudication in nature, non-healing leg ulcer by default, and abnormal, of course, lower extremity pulsation. And when you go to that, you have to understand that the status pedis artery is absent in about 2% of the population, congenitally absent. But it is non-palpable in about 12%. And the reason it's not existing as much as just hard to find, just a smaller artery or has a deeper course, not the usual course. And we tend to use, just simplify what we use, 0, 1 to 2, and no more brisk pulsation. So what are the helpful signs and what are the unhelpful signs? So let me talk about the unhelpful signs, although I do it in every peripheral arterial disease clinic that I have. Look for the color, look for the capillary refill time, and I document that, and also absence of the hair growth and atrophic skin. So most of these people are older. I mean, usually they have an atrophic skin. Usually they don't have hair in their legs, even if they had it when they're younger. I feel I lost some of that too. And so it's not really about that anymore. I mean, are they important and we have to look for them? Yes, they are important. You have to look for them. But I don't think that there will be helpful signs. The more helpful signs will be abnormal pedal pulses or unilateral fold extremities, then prolonged venous refill time and femoral bruit. And those are felt to be really the most important ones. Elevation, pallor, and dependent rubor is very important, which is, you know, different than the prolonged venous refill time. So they are similar in a way that you will, elevate the leg high up for maybe 1 to 2 minutes if you can, and with the help, of course, of the nurse or yourself. And then you put them down at the side of the bed and wait for that rubor color to happen. And if that's, you know, the case, then definitely you have a significant peripheral arterial disease, and it is mainly because of the reactive hyperemia that happen and vasodilation of the circulation in the peripheral arterial system. So then we move on to the hemodynamic, testing. I hope that I'm doing well with time. So ABIs and exercise ABIs. Exercise ABIs are very important in case that the ABI was normal and you still think that there is significant peripheral arterial disease, then exercise ABI can help you to identify people at risk. Segmental volume minutes. Brachial, and you take the highest of whatever you have, PT or AT, you divide the ankle on the brachial, and if it is less than 1, then you probably made the diagnosis of peripheral arterial disease. And then, as you can see in this slide, that's how you define in terms of borderline, supernormal, mild disease, moderate disease, severe disease. If yours is normal, and sometimes it's high even to compress the artery, so it's going to come NC, non-compressible, then you have to use the, either TBI value, which is if it is more than 0.7, then most likely you have a normal circulation, or you can go to another modality, exercise ABI, or you do a duplex ultrasound. This is the exercise ABI to unmask any, hidden disease. And if it is abnormal, usually it reflects an inflow disease, high in the aorta, iliacs, or maybe common femoral artery. And then the segmental pressure, as you can see, you take really, as the name tells, pressures at different segments of the of the leg, and you compare both legs together and each segment with the other. It's really not very accurate because sometimes the habit of the body habits of these patients, sometimes it's just not very helpful in this test, but it is helpful when it is done correctly and has enough information about it. And this is the PVR, and you would like to see really a normal values, which is here, and to some extent a normal tracing. And the tracing here is a little bit blunt, but again, your total ABI is normal. So there might be an underlying mild peripheral arterial disease. And also what you look for, also the augmentation, meaning that your brachial, in the circulation, the far away from the heart, the higher the pressure. So basically, your SFA pressure should be higher than your brachial. Your popliteal should be higher than the SFA and the brachial, and furthermore should be higher than your brachial. And this is exactly what augmentation means. So loss of that augmentation, if it's done correctly, that can give you a sense of underlying peripheral arterial disease. As you all know, this is the ultrasound, and you're looking for the triphasic wave. If it is biphasic, still normal, maybe underlying disease, but not significant. Monophasic, more severe disease. Unblunted, of course, severe disease. CTA is now the number one. But you have all the information mapped very well. You can really map your case. You can, know exactly what you're going to do, whether you're going to do pedal or femoral. It's going to be helpful. It's not for screening. It's more for diagnosis and mapping of your intervention. So what should we do and how we do these things? So you take a perfect good history and physical examination. If you think that the patient might have a peripheral arterial disease, you continue with ABIs, and if the ABI is less than 0.9, then you made that diagnosis. If it is more than 1.3, then you have really to know whether there is or there isn't peripheral arterial disease. That's where you go for segmental pressures, PVR, or exercise ABI, ultrasound, or CTA. So the guidelines, and this is a cramped, slide, but in a way that the guideline says confirmed PAD, risk factor modification like anything else, and goals for hyperlipidemia, diabetes, and then you go for pharmacological risk reduction and risk reduction of cardiovascular event, not for PAD, and then treatment of claudication. But what I'm trying to say that it is really a pan-vascular systemic disease. It's not just, this is a problem. Once you make that diagnosis, you're already committed to problems in the heart and the cerebrovascular and the renal, everywhere, carotid, etc. And prevention therapy is the key, and hygienic and skincare is very important because these people are really very vulnerable for a lot of future problems if you don't teach them early on how to take care of their feet, even in the absence of diabetes. I'm not talking about only those who are diabetic. So it is really a multidisciplinary team management. It's not only just a interventional radiologist or interventional cardiologist or vascular surgeon or interventional vascular surgeon that should be handling these people. This is like the endocrine people has to be involved. The infectious disease people have to be involved. The just name the rehab people has to be involved. So there's a multidisciplinary team that has to be involved in the care of those patients, whether they are diabetic. I'm repeating again, whether they are diabetic or not, they have to be a multidisciplinary team for this issue to prevent future problems. So confirmed PAD, yes or no, no significant functional disability, then no claudication treatment required. Just follow up and make sure that you do the same thing again and again. If yes, there is a life limiting, then you think if there's a lifestyle limiting symptoms, if there's a lifestyle limiting symptoms, maybe an evidence of inflow problem, you may take care of that by either vascular surgery or by endovascular therapy. Regardless, if that happens, you continue the same cycle of screening and management as per guideline. If not, and this is the middle segment, then usually the guidelines says you do one or the other or both. And I think both would be better to simplify and really create a fast-track therapy. So in a way that you start patient on silestazole, for example, and you give them a prescription for exercise. Exercise is very important, which we'll come to it in a few minutes. And then both together, you can probably, if you can do both, you can give them 3 to 6 months trial, and then if not, then you can go for endovascular or vascular surgery therapy. So exercise training on claudication, this is the effect of a monitored exercise, and you can, as you can tell, also claudication and pain improved significantly by exercise training, and also even the maximum claudication of pain improved significantly. So we know for sure that monitored guided exercise is helpful. Intermittent claudication, this is from New England Journal of Medicine, where they actually ask you to write a prescription in this manner for the patient, where you tell them that you have to really do it at least 3 to 4 to 5 times, supervised sessions of exercise, and duration of at least 35 minutes, and treadmill or even a walking, and the lunch should be at least for 6 months. The problem that most of the payers here in the United States will not cover, so you're really stuck. Some of them they do, which would be good, but you can really manage by if they have a coronary artery disease or heart failure, because that can be paid off as a rehab. So you can set them for coronary artery disease rehab or heart failure rehab, and you can implement what you want in to help them with their peripheral arterial disease. So how about unmonitored? Unmonitored was also studied, but unfortunately it's not as effective, of course, because patients may not be as religious and compliant with it. But that's what we end up doing at the end. I mean, most of our patients will give them the same prescription, try to do on your own whatever you can do. And some of them, they can take it seriously. But of course, unfortunately, the majority maybe not. Smoking cessation, smoking cessation, smoking cessation. At first, you can say stop smoking, followed by smoking cessation, followed by quit smoking. There is no way around it. There's nothing except stop smoking, decrease amputation, decrease need for revascularization, decrease the failure of bypass or stenting in the vascular, and improve time. So it's very important. So come to antiplatelet, anti-thrombotic drugs. So, you have to understand here that using of aspirin or antiplatelet therapy, it's not for peripheral arterial disease, and it's not like what for example, clopidogrel or Plavix company wants you to put everybody with PAD on Plavix or other alternatives. That's not the case. These are only for cardiovascular events, not for PAD. So you're treating with aspirin, and baby aspirin, what we call the 75 to 81 milligram aspirin is more than what you need. If they are not, or they are allergic to aspirin and use Plavix as an alternative, you don't need dual antiplatelet therapy in peripheral arterial disease. And again, what you are aiming is reducing the events, cardiovascular events in terms of my cerebrovascular accidents, etc. And these are some of the studies that showed the difference between placebo, aspirin, and Plavix, placebo and ramipril, which ramipril is a class 2 indication to be used in peripheral arterial disease, also placebo and simvastatin, which all the indication what we need to do. So all patients has to be on aspirin at least, or alternatively Plavix. All of them has to be on cholesterol medicine. In terms of ACE inhibitors, it's a class 2 indication, so they don't have to be on it. There is no therapy or no rule for vasodilators in peripheral arterial disease. That's just a myth. So as I said, antiplatelet therapy, it's not for claudication symptoms, it's only for cardiovascular events. And the only thing that's approved by FDA is pentoxaphylline and silestazole. Pentoxaphylline, forget it, don't use it. It's just a waste of time unless you cannot unless that it's the only choice that you have. But what you can use is silestazole. Unfortunately, if you have 100 patients on silestazole, maybe 20% of them to 30 that will really tolerate the medicine, will be really, candidate for it. And of course, you can't use it in heart failure. There is the contraindication is drawn from milrinone, which is in a similar class to salicylol. It's not from salicylol itself, but nevertheless, there's a black box warning for the FDA, and we cannot use it in failure. Salicylol is a great drug. It decreases HDL, decreases triglycerides, and prevent platelet aggregation. And also, it's a vasodilator. And it does really help, and you can see this slide combination of the placebo, pentoxifillin, and salicylol, and you can tell the difference between pentoxifillin and salicylol in this group of population that was found very helpful. And again, it also improves the ankle brachial index. Problem of salicylol is the complications, and as you can tell, a great amount of headache. And also diarrhea, abnormal stools, palpitations. Again, if you add that to the population of people that they have heart failure, I mean, in the cardiology, at least clinic, you're limited how many of those patients that they're going to be effectively on salicylol to gain the benefit of salicylol as a therapy for peripheral arterial disease. In the vascular therapy for claudication, let me just stop here for a second. As I said, this talk is really just to raise the awareness of peripheral arterial disease. It's not intended to discuss the management, because my plan, and I try to invite several people, at least 4 or 5 from radiology, interventional radiologists, and vascular surgeon, that they are really heavily in the work here in the United States, Canada, and also from across the seas. But unfortunately, I don't see their names. I was hoping that they join us, because I was trying to get them involved so we can really carry on, several talks in the future between all of us, where we can really cover peripheral arterial disease. So this is just an introduction. If the others are not interested, and I'll try with them again, then maybe I need another 6 to 8 talks to cover very important issues in the peripheral arterial disease, and then we can move to the venous system later. So this is a statement that it's a very important statement. I was in the Viva conference just early November, and everybody says that our guidelines are really outdated, because most of the current guidelines are based on the 80s and 90s data. They're not based on now. I mean, the technology is enormous. It's just you won't believe how much you can do in the vascular rather than open. And it doesn't mean that there is no room for that. No, this is not the case. The case there is room for a lot of vascular procedures, open vascular procedures. But I think the technology is so advanced that there's a lot of things that we can do without going for surgery. So, endovascular, procedures are indicated for individuals with a recreational or life-limiting disability due to intermittent claudication. Of course, they have to be on all the medications that we talked about. If the response to exercise or pharmacological therapy is not adequate, or if there is favorable risk-benefit ratio, so you have just to weigh the risk and the benefit between doing nothing, surgical approach, endovascular approach, and that take anatomical suitability, comorbidities, of course, resources and the skills and expertise that you have, and patient's preference to, and most importantly, that's not on this slide, the culture that you are practicing in. This is very important. Everybody has to be buying in your approach, otherwise you're going to be really especially in this gray zone of management. There's no clear guidelines. It's going to be very, very challenging. And of course, in any critical limb ischemia, endovascular therapy comes really the priority in general. And I think we talked about all the cases, so I'm going to just move on with all these slides. We already discussed the 6 cases, so I'll just go to the summary and then we'll see discussion where it goes. So PID is common and has significant impact on cardiovascular outcomes and reflects systemic disease. Treatment of PID, even asymptomatic, should focus on risk factor modification, risk reductions. Treatment for intermittent claudication should include exercise therapy, drug therapy, and selective use of revascularization approaches, whether it's surgery or endovascular. Treatment for critical limb ischemia warrants aggressive efforts like revascularization, including surgery to reduce the risk of amputation. And again, I hope I fills up your tank a little bit about the PAD and the awareness of PAD. And whenever you see something indicative of a small, tiny ulcer in the toes or the foot, I think the problem is far, far, far bigger than what you think. And thank you very much.
Thank you so much, Mehiar. Outstanding presentation, and congratulate you for this excellent work. And also congratulations for you being on time. So you were sharp on time, so that's excellent. And we have at least 15 more minutes for discussion. I'm sure there will be lots of questions coming up. So please.
Did I miss any comment or questions in the past? Those
probably. I think you were caught up with them, but people can still ask questions about Mehiar's presentation, and also if you have any questions, burning questions from Adel Dyub's presentation. I think Adel is still with us, so you can ask Adel. And while waiting for questions, Mehiar, I have a technical question, and I also have a question about a couple of the slides. A technical question: I see that you put a stent across the joint. Is this something doable? Can you put putting a stent across the joint, would that increase the risk of kinking or something like this?
Right. So, definitely. You try always to avoid putting stents across any active joints like the common femoral artery area or the popliteal artery. There's no question that's not the intention. But of course, when you're dealing with the bailout, procedures, you probably have to. But there's few options. So if you use Nitinol stents, they still can kink and can create a problem, but they are less than a bare metal stent. So this is one option. The other thing, if you use a covered stent via bond, for example, that shouldn't be a problem. You can. Another stent that I use heavily in the common femoral because it's just a most of the stent fractures are happening in the common femoral area, artery area. That's called supera stent. The supera stent is really a circular stent, basically. And once it's very, the deployment of supera stent is a little bit problematic by itself, the technique of it. But once you really gain the confidence on supera stent, you can put them in any movable joint area. Very strong, they don't kink, they don't fracture. The fracture incidence of supera stent is 0%. There's no fracture at all reported from supera stent. So you can use maybe supera stent if you want to be on the safe side. But again, you shouldn't unless this is a bailout issue. It's not really, shouldn't be an intention to treat, to stent around joints.
So just a bailout in case if you need to.
It's not a good candidate for surgery, or you created a perforation in an area that you want to really just bail out yourself. That's all. Otherwise you should not. And last case that I presented where that stent the popliteal, I agree with you, but again, that intention is to take the patients from the gangrene that he had and did. Then, as I said, Dr. Mehiar was able in 3 months to go ahead and do the bypass, which they couldn't do at the beginning of 3 months prior to that.
Outstanding. So this slide, we're waiting for a question. If you have any question, please, you can ask for the mic, click on the smiley face and raise the hand, or you can type your question. While waiting, Mehiar, so this is a fascinating slide. So it shows long-term survival, increased. Now, so asymptomatic patients, and it's probably survival better than symptomatic patient based on the slide. Like we're talking about 12 years here. So
true.
I don't understand the slide before it though. The slide before it. So the yellow is asymptomatic, the red is symptomatic. So what's the difference between this and this?
Female and then male. So the one on the left side, male population, one on the right side, female population. So basically it says whether they are female or males, there is no difference. They carry still the same risk, still the same thing. So.
Okay, fantastic, great. Clearly the as you indicated, coronary intervention relative to peripheral intervention is much easier. I think peripheral intervention sounds like it's more complex, but there's also more creativity and more challenges with the peripheral compared to the coronaries. and
Right.
lots of techniques.
Intervention is well established. Your room for creation, meaning that you're asking for trouble, basically.
Right.
You don't have much. Your creation is more in whatever somebody else did and documented, and you're just going to try to refine the same work, maybe with either a better outcome, let's say, of your intervention. In the peripheral, really, there is no set guidelines. There's only guidelines in terms of what should you do next, but not how you do it. In the coronary, the guidelines went even through the steps how to do things. There is really steps how to do things and where you should avoid whatever you should avoid. In the peripheral, it's not there yet. And I think because the technology in coronary has gone far, more than the peripheral. And just because of this data that we are showing right now people, even the vascular surgeons, most of them right now, as you probably well know, are interventionists. So in the past, you do have a group of vascular surgeons that they only believe in bypass. And then you do have interventionists, either radiology or cardiology, that they believe in intervention. Now, the three groups can do intervention. And I think that really allowed for advancement of what we can do in the peripheral intervention. You see, I think a question, can you apply the same Doppler criteria for stented arteries as in native arteries? Oh, great question.
Yeah, follow up.
Yes, it is a very good question, actually. Thank you, Haytham, for this question. When you do duplex ultrasound for after stenting, actually it's probably better than doing an ABI in general. So you're looking for two things. Number one, you're looking for the stent itself and whether there's any problem inside the stent, which you can really see it very well in the ultrasound. And the other thing that you look for is the velocities, as you mentioned. And yes, you use the same thing because, as you can tell in the duplex ultrasound, if your velocity post-stenosis is very high, that means that there's a severe stenosis. That's what you look for, basically. Is that change, post-stenotic change in the velocity, which is true. For follow-up, anybody that has a bypass, you should not do ABI. Anybody with bypass should go for ultrasound, duplex ultrasound. So bypass should not go for ABIs. You
mean lower extremity bypass?
Yeah, sorry. Yeah, I'm lower extremity bypass.
Right. So people may confuse with coronary bypass.
No, sorry. Yeah. For anybody that has a lower extremity bypass surgery should only follow by duplex ultrasound. Because the duplex ultrasound, you can really evaluate the whole bypass graft, whether it's a synthetic or the venous graft, and also you can assess very, very, very accurately the anastomotic side on both the proximal and the distal, and of course, you can have an idea about distal circulation. So ABI is not great for that. But if you have a stenting, you still can do ABI and not necessarily do a duplex ultrasound.
Mehiar,
yes.
Sorry, I thought you finished. No, go ahead. I'm sorry.
No, you can go ahead. I think I'm almost done. Yeah.
Yeah. So we definitely need more of this presentation. I think you brought up a great point, which is the awareness, because most of us, we don't do the peripheral, but we need to be aware of this. So let's do this. Let's ask the audience about which percentage of them routinely check their patients for symptoms of PAD. And the next question would be, I prepared this while you were talking, so let's see what's the impact of this. So go ahead and vote, please, for how often do you, or for patients do you routinely check your patient for possible symptoms of PAD when you see them? I assume either internal medicine, cardiac surgeon, any specialty. So, because this may be under, so go ahead and answer this question, please.
I'm gonna answer Khalid Bgaya.
Okay, yeah, go ahead.
The United States now, I can tell you that maybe 60% of work is done by interventional cardiologists. Maybe about 30% of the work is done by vascular interventionists, and maybe about 10% by radiologists. It depends, of course, and it's varied from one place to another, one city to another. In the city that I'm in right now, it's mainly interventional cardiology, interventional radiology. but I've heard from different people, and there's also even a study that was released that actually the number was as up as 70% interventional cardiology. And again, it can be variable between one place to another and one city need to another city need. The other thing that why it's going to be variable also whether it is an academic institution versus a private institution. So in the United States, of course, because you know some of these cases takes about 2 to 3 hours to complete. A private physician will not waste his time in a leg ulcer and spend 3 hours to open an artery for let's say pennies of money. So that's by default is really something that most of the academic people or people who are owning a fixed salary, if you will, they will probably be more aggressive and do more work than the others. So the question is yes, in 30%, sometimes in 20%, and no until it complains in 10%. Yeah. That's very, very, very nice. I mean, I'm glad there is a percentage said yes, always. I mean, since you know, so I came to residency here, I always ask the questions. I always examine, but I never realized the extent of the problem. So my question will be, did you realize the extent of peripheral arterial disease and the consequences of peripheral arterial disease when your patient says, I have claudication, or when you examine the foot and there is decreased pulses, or there is bruit in the femoral area, or there is a patient that has below knee amputation? Did that at any time reflect how bad is the situation? I think this will be really, at least this is the one that is fascinating me. Yes, as a physician, we should really examine and we should really be aware of taking history and examination. But I think my awareness goes beyond that. How much do you reflect into that? That will be very important.
I think Adel Dyub has a question. Tafadhal, Adel.
Yeah.
We can't hear you.
Yeah, good talk. Just to comment about, this is obviously to me, it's very important, peripheral vascular disease, and I think it's very related to our specialty. And when we do coronaries, and especially lately in the last probably couple of years or 3 years, I started doing a lot of minimum invasive valve and bypasses. And one thing, the first thing I check is pulses, of course. But just having the pulse itself is not enough. So most of my minimum invasive, I usually CT their abdomen, pelvis, and chest, and make sure that everything is safe for cannulation. And one thing also more that we do lately for coronary is we map the vein, because when I first started training here, efficient expedition, you open one leg, you find vein is not usable, you open the other leg from ankle to the groin, so you end up having 2 pieces of vein to establish 4, but the guy has 2 legs cut all the way across the knee. So in the last 4 or 5 years, I was begging and pushing for mapping the veins before we come in, because you'll be surprised how many people were shocked when I go and talk to them. We said, for vein, when we cut the leg to harvest the vein, whether you're peripheral vascular disease, whether you're normal, you're fat, whatever, you just go, feel, palpate, it's fine, just go and look for it. It change, it bifurcate, you go up, the groin is usually the bigger vein, the better to use. But since last 3 years, mapping the vein, it's been very, very useful. I mean, this is an advice to people who practice and doing bypasses and harvesting veins. If you map the vein, you will be cutting exactly what the patient needs, and you'll be avoiding a lot of peripheral complication after surgery. The second question, second question, do you have in your institution, or those who does bypasses or deal with coronary disease, do you treat these people differently? Like, do you is there any form of rehab for peripheral vascular disease? Like, we send them for cardiac rehab, for cholesterol, for smoking cessation, for this and this. But is there a specific particular rehab for peripheral vascular disease, which I think might be something useful for these people to, because a lot of people come to me and follow up, they say, well, chest is fine, I'm breathing better at walk because of my leg. And it seems to be an issue that's under evaluated and under services, because a lot of people tell you, my knee hurts or my calf, I can't walk because of my thigh hurts, or I think it is very underlooked and under-evaluated and underestimated and under-treated condition.
I'm sorry, I did not hear most of it, but I think I understand your question. And I'm gonna, it's very common once you, whether you do bypass surgery or you take care of aortic valve because of severe, symptomatic severe AS, or you do stent, in the heart. The limiting symptoms of that patient is already resolved, and now the patient feels better and wants to move. But at that time, nobody looked for peripheral arterial disease in that patient, and they now have more symptoms related to the legs, or vice versa. Sometimes people have a severe PAD and they can't walk more than 50 yards or even 50 feet. And then you fix their legs, then the next thing happens that they come in with the angina of the chest, and now you have to do workup for the coronaries. So as I said, if you made the diagnosis of peripheral arterial disease, you should really start with exercise. You should start with maximizing medical therapy, risk factor modification, cholesterol if possible, and exercise protocol, which is the New England Journal of Medicine exercise protocol that I mentioned earlier. If that failed, then you should probably go further for imaging and intervention, whether surgical or in the vascular.
What I'm trying to say, is there a dedicated team in your institution that is dedicated to this kind of, like, there's a rehab for peripheral vascular disease? Because I don't think we have one in our place.
No, because it's not paid by the insurance, so there will not. And it will never happen until it is recognized by CMS, Medicare, Medicaid, and other payers, where there's something that has to be provided to the patients. Then, hospitals will invest. Now, unfortunately, in the United States, it's all money-driven approaches. If you're not going to be paid,
reactions, it will probably take care of a lot of, make these people stay outpatient. I think it makes sense because the disease burden is high, and
I agree, but the reality is existing.
Keeping a close eye on those people might.
Right. I can challenge you, even look for the rate of amputation. A lot of centers, they don't want to look into that. It's very high in most of the centers around the globe. And a lot of people, they don't want to look them. They don't want to even, count how many amputation percentage they have, and whether they. I can tell you that. I saw one in this meeting in his institution. He said that they caught 3 or 4 amputations without even a CTA or imaging done. So the decision of amputation was just based on a clinical decision. So all these are really, and that's what I'm saying. This peripheral arterial disease is really not being covered well and not being handled well, not only in the United States, it's everywhere out there. It's not, it didn't take much because, and it does really create a lot of, the cost issues of peripheral arterial disease is tremendous, like any other problem, more than cancer in this country, and I'm sure everywhere else. But unfortunately, it's not yet, addressed well. I'm not sure why, but I'm sure there's a lot of politics. Because if you try to target amputation, you really kill the surgeon. If you try to promote, other modalities, and I'm sorry to say this, but this is the reality in anything, right? We do. It's like when the TAVR came out. The CVT said that either we are in it, with all respect to you, Adel, or it will never happen. It's as simple as that. It was really a battle. Either we can put TAVR like the interventional cardiologist, or we're gonna block this until they came to
I think I don't want a fight happens here between a surgeon and cardiologist. But while I want people to.
There's a lot of rule in this. Really. Right. Right. He's upset. There should be more investment in this.
So Mehiar, while people, I put another question. So people, let's see what's the impact of your presentation today on people who attended this. Let's see if we learned something from today's presentation and we start thinking more. So I'm not going to show the results yet, but people, please vote. Yes, absolutely. In future, you will try to screen all of your patients for PAD, or maybe, or not sure. So please vote. And while people are voting, Mehiar, I'm going to ask you a question. I don't see any other question, but a real question. It's almost a theoretical thing. since you're a cardiologist who does the peripherals, so which is a nice combination, do you see a role for, and since we know most people with peripheral arterial disease die from heart attacks, is there any role for drive-by coronary angiography? Like you do the peripheral, you fix the iliac or whatever, and then you slide the Judkin right, Judkin left, have a quick look if you see a left main, and then go for it. Probably there's no data done about that, but do you think in future there may be a role, since you salvage the limb, probably you may as well look at the heart and salvage it since you're there anyways?
I don't think so. I don't think that will. I don't think that will happen because basically you try to. Have you done this? Yes. Okay. So to answer the question, again, I see Dr. Adel said that too much contrast, and I agree 100%. We try to minimize other risk issues during the procedure, but
let's say 4 French, 5 French. 2 views for the right, 2 views for the left. This will add only like 20 cc of contrast.
I didn't answer the question there. So we try really to develop anything we do based on symptoms. Because, if you take me now to the lab and you do a heart catheterization, you might find 70%, 80% RCA. I jog, I'm doing fine, and I'm okay with it. Don't put a stent, leave me alone. And also the guidelines says that. So you really don't want to put yourself in a situation where you can find a problem and then you try to manage. So I would say the answer would be no, and I don't think it will change at all.
Great.
I don't think
excellent.
So. Yeah.
So no drive-by coronary angiography.
No. Shouldn't.
Okay.
Similarly for renals, don't try to do heart catheterization, and for hypertension you check if the renal artery stenosis is existing or not. I've seen it done. I've done it a few times, but I don't think we should.
Yeah, and Adel Dyub also is with that. Okay, so Adel, we try to create a business for you. Try to pick up left mains and send them for you. Okay.
Yeah.
And
I can be in jail too. Yeah.
And Dr. Khalid Hadili says will not be covered. Absolutely, I think if not symptom driven, not be covered. Great.
Just a quick comment.
So
you mind?
Go ahead, Adel.
When I go, there's a place I go to, which is, it's a Thunder Bay. It's about an hour and a half by flight from here. Every angiogram by the 4th intervention is there. There is a renal shot and peripheral shot. I'm not sure how common this practice is. They do it for everybody: hypertensive, non-hypertensive, renal, diabetic. Pretty much all the images. So renal shot and a peripheral shot.
That's wrong.
Every valve, there's measurement for TAVI. 45 years old with bicuspid severe aortic stenosis, you'll see the measurement of the root, you see everything. So I'm not sure if this is a practice across, or this is something that people do.
No, I don't think that's the right thing.
No, that's completely wrong. And for TAVI, you don't need even to do an angiogram at all. For TAVI, you need to do a CTA. And then you can do a heart catheterization if you think there is to put a stent or something like that. During the procedure, you use angiogram for the clasp. That's all. So.
I agree, Mehiar, the same thing. The only thing is if I use a femoral approach, toward the end, we usually do a lifted shot before deployment of device, before deployment of angioseal or periclose or something, to see where is the location. That may, in cases, I've seen a few of those, it shows severe disease there, either at the SFA or iliac, etc. So these ones, we usually refer them to an interventional radiologist or a cardiologist who does peripherals. But routinely checking the whole arterial tree, I think it's not at least a valid practice at this time. There's a question, Mehiar, from Dr. Abdul Wahab, which is a very nice point. He talks about secondary screening. And maybe if we rephrase the question, Dr. Wahab says if you have for prevention, because we know those people will die from heart, not from their limb ischemia or whatever. So the question is, how often do you have a patient who you fix their limb and they have bad disease? Is there any routinely checking do you send them for stress tests after that, or maybe scan or perfusion scan, so they might have risk for heart disease? What do you do to intrude on that area?
Well, I mean, the guidelines does not indicate that you do a stress test for those people. Let's just stop there first. Second, I mean, you go with the usual, risk factor modification by, aggressive antihypertensive therapy, diabetes if they're diabetic, and also anti-hyperlipidemia therapy, with the daily aspirin. If they are symptomatic at that time, if they are symptomatic, then you go for a stress test. If they are not symptomatic, there is really nothing should be done. You just have to wait.
So wait for them until die from their heart?
It's like anybody else is sitting in his home right now that doesn't have a peripheral arterial disease, but maybe diabetic. You stress every diabetic patient they are asymptomatic? You don't, right? So if you have a diabetic patient, you don't stress them. Are you waiting for them to die from coronary artery disease? No, but you're waiting for that moment of shortness of breath, maybe silent ischemia, angina equivalent, whatever it is. When that happens, that's the time where you can be aggressively screening for coronary artery disease. The combination of PAD, coronary artery disease, is it's high. It's 40 to 60%. It depends. So it is very high, but yet we cannot really just automatically screen with a stress test for those unless they are going. Oh, let me tell you, do I cheat around the system? Yes, how? If somebody is going for kind of surgery, okay, then I will do a stress test for that patient. So now I know, but not just because of somebody that I treated endovascularly or I know that has peripheral arterial disease, I do not screen automatically for those.
Because somebody may argue that because of their limb ischemia, they were not walking enough, so they produced their angina. I mean, it's hard to tell.
Those are untreated. Yes.
Right.
Yes. Right. Those who are untreated, then you already said that because I cannot assess their angina as they are not functioning. Correct? Then that's a different story. For those who are really treated and walking, I don't think you can.
Excellent. So there's, I think, a couple of questions from Adel, and let's finish the voting because we're almost running out of time here. So Adel asked about carotid disease, left main. Would you advise for at least a stress test? Somebody with carotid disease. And Haytham.
What's the question? I'm sorry if
you can read it there, Mehiar.
Okay, well, I will.
Okay, so I think you answered the Haytham, Dr. Abdul Naas question in diabetics.
With Dr. Naas, in diabetic, if you wait until they are short of breath, it might be CVD. In diabetic can be the presenting disease. Yeah, what I'm trying to say is the guidelines does not give you privilege to do a stress test for diabetic without some sort of symptoms. So, I mean, yeah, I agree. If they are going for surgery, vascular surgery, any form of vascular surgery can set them for a stress test. So that's the answer. I did not read what Dr. Adel said. I think I missed it. Good. For what you think about disease and what means disease, I would advise for at least a stress test. Carotid disease and not only left main, coronary artery disease in general. I mean, not only just the left main. That can be. I mean, there's really a controversy about that, Adel, because, sometimes, the only time that you can be in, if it is a left main. I don't know how many percentage of people that they will have carotid and left main. I mean, you look for disease rather than wait for it. I agree, Naas. I mean, what can you do? So how are you going to look for it, the disease in diabetic?
Yeah. So remember, I mean, guidelines are they just guidelines? They are not everything.
We do practice differently.
Right. They cannot replace.
I can't tell you what I do in everyday business.
All right. Cannot replace clinical judgment. I think since we're running almost out of time, we're gonna show the result of this voting to see if people benefited. Mehiar, are you ready?
Yeah.
Excellent. Maybe. So not everybody, so 60% people may not have answered this, but most people who answered, at least everybody either absolutely will check their patients for PAD in future, or maybe if they remember to do so, which is less, maybe I think it's 1%. But again, this is a limited number. Not everybody applied to the poll. outstanding presentation, Mehiar. I certainly myself learned a lot, and I think we should ask you to present this. The topic is not finished yet. I think the discussion is still going. We need more of education about peripheral arterial disease or arterial venous. And also thank Dr. Adel Dyub for his outstanding presentation, challenging case about aortic valve thrombosis, and thank you all for attending the 31st Libyan Cardiovascular Webinar. Our next webinar, I think, is going to be, according to Dr. Khalid Bouzgaya, the organizer, is I think is December. Thank you, Khalid. December 13th. So that's going to be our next Libyan Cardiovascular Webinar. Thank you all for attending, and God bless you, and see you later, inshallah. Assalamu alaikum wa rahmatullah.